What is up, beautiful people? If you know me, great! My name is Tiago and I am a nursing student. Today, we are covering upper and lower GI for adult health. The main conditions are GERD, peptic ulcer disease, gastritis, hiatal hernia, IBS versus IBD, ulcerative colitis and versus Crohn's, diverticulitis disease, bowel obstruction, and colorectal cancer screening. Guys, if you don't know me, now you do. This is me teaching myself out loud using the same structure I use in my nursing notes. Okay, that is the Tiago 12-point framework. What is that? It is a method I literally built to fully grasp the concept of nursing and to pass my exams. Okay, all right, so I'm gonna go with you. What is the 12-point framework that Tiago built? Okay, and it starts with what is it? What does it look like? What can go wrong? What do I monitor? What do I do? What do I teach? What is the priority? What cannot go together? What looks similar? What is the emergency version? When I assess first? And what chain I need to trace. Okay? This is the framework that forces me to turn the disease into a nursing decision, right? Because the exams that we are going to be getting are individually different. But if we understand these 12-point framework that I have analyzed and constructed, because from the exams that I've taken before, I had to build from on top of what I was missing because I wasn't being taught it. So this is me helping myself teach me, and hopefully this works for you. Okay, so as we go through these slides, I'm going to keep asking the same questions. What is the problem? What am I supposed to notice? What would scare me? What would I do first? What is the exam trying to make me confused with? And quick study with Tiago note before we start. If you want to follow along, the GI, my note packet, flashcards, and practice tools are linked in the description. The point is to watch, pause, look at the visual map, and then test yourself instead of trying to hold the whole GI unit in your head at once, right? Okay, awesome. Let's get started. Okay, so allow me to really describe what's going to happen. Okay, so for upper GI, I want to separate GERD from cardiac chest pain because that is a safety issue, right? I want to understand peptic ulcer disease by cause because H. pylori and NSAIDs do not tell the same story. I want to recognize the hiatal hernia emergency signs. And I want gastritis and dyspnea to stop blending together in my head, right? For lower GI, I want IBS and IBD to become obvious. IBS is functional. IBD is inflammatory and structural. Then inside IBD, I want ulcerative colitis and Crohn's to separate cleanly, okay? So UC is colon only and continuous. Crohn's can be anywhere, has skip lesions, and is transmural, right? Then I want to move into the emergency logic, right? A bowel obstruction can build pressure, loose blood flow. Perforate becomes peritonitis and turns septic. That chain is what makes the topic make sense. And last, I want the medication review to stay tied to the condition. PPIs, H2 blockers, antacids, mescaline, and steroids, right? The biologics and the drug teaching traps only matter because of what is happening in the body. And here you go. This is the breakdown of my Tiago 12-point framework, right? The clinical review of what we're doing in the exams. And this is what I've built to really break down how I am going to answer these questions. And this is the best way for you to follow as well. So go ahead and take a screenshot and please use the description below to review the packet and to really grasp these concepts. As you can see, I love the pictures. I love the colors. That's me. All right. That's how I do it. Okay. Let's get started. For this section, I want to keep the body map simple. Upper GI is the esophagus, the stomach, the lower esophageal sphincter, and the first part of the small intestine. Most of these problems show up as burning, pain with the meals, reflux, nausea, bleeding signs, or swallowing problems. My job is to sort out what the symptoms is pointing to, right? Is acid moving upward? Is the stomach lining inflamed? Is there an ulcer? Is part of the stomach sliding through the diaphragm? And most important, is this actually GI or is the patient describing something that could be cardiac? Hmm. Right? So that's what's going to help me understand GERD, right? The stomach lining helps me understand gastritis and ulcers. The diaphragm opens and helps me understand hiatal hernia. And the duodenum helps me understand why some ulcer pain improves with food and then comes back later. So when I hear a patient say it burns after I eat, or it gets worse when I lie down, or I got black stools, I do not want to memorize just the words, right? I want to locate the problem in the GI tract first. So location helps the whole question make more sense. Don't you love my little pretty pictures, right? Don't you see that? Look how cute this is. Anyway, when the lower esophageal sphincter is weak or relaxed at the wrong time, stomach acid can reflux upward into the esophagus. The esophagus is not built to handle acid the way the stomach is, right? So that is why the patient feels burning behind the sternum, especially after meals, bending over or lying flat. What do I need to remember clinically is that the GERD is not only discomfort, repeated acid exposure can inflame the esophagus, causing narrowing, contribute to swallowing problems, and in some patients lead to Barrett's esophagus. Barrett's means the tissue changes because it's trying to adapt to the chronic acid exposure, and that increases cancer risk, right? So the nursing thought is treat the reflux, teach the lifestyle changes, assess for red flags, and never ignore chest pain just because the patient says it's heartburn, right? So picture the stomach as a hot sauce bottle with a loose cap, right? When the patient lies down, the hot sauce leaks, right, upward, and it burns the tissue that was never supposed to touch, okay? So the pain is usually burning or sour. It often happens 30 to 60 minutes after meals. It gets worse when the patient lies flat or bends over because gravity is no longer helping keep acid down. It may improve with antacids, sitting upright or avoiding the trigger food, right? But other clues include regurgitation, sour or bitter taste, belching, sore throat, hoarseness, right? And the chronic cough at night. The night cough matters because it can trick me into thinking respiratory first, right? But if the cough is worse when lying down and paired with reflux symptoms, acid irritation is part of the picture. The red flags I do not want to miss are dysphagia, unintentional weight loss, GI bleeding, persistent vomiting, anemia, or severe chest pain. Those are not just reflux findings, yeah? Okay. So this is the safety, right? GERD can feel like chest burning, but MI, right, myocardial infarction, can also present with chest discomfort. So even if the story sounds like reflux, the nurse does not dismiss chest pain until cardiac causes are considered. So GERD is more likely when the pain is burning, meal related, worse lying down, improved by antacids, or sitting upright, and not paired with cardiac symptoms. MI is more concerning when the pain feels pressure like, crushing, heavy, or tight. When it radiates the jaw, right, the shoulder, the left arm, or the back, when the patient is diaphoretic, short of breath, nauseated, pale, weak, or has risk factors, antacids not helping is another clue that this may not be simple reflux. Okay? So, my test taking rule is the question gives me chest pain plus cardiac warning signs. I choose cardiac assessment and workup, right? ECG and troponin logic comes before treating it like a heartburn. Is it safer to rule out the emergency first? Right? So remember, heartburn can wait, all right? A heart attack cannot. If the chest pain brings sweat, shortness of breath, jaw or arm pain, I leave the stomach and check the heart. Copy? Elevate the head of the bed about 30 degrees. The teaching point is not just use more pillows, right? Because pillows can bend the patient at the waist and increase abdominal pressure. A wedge or elevating the head of the bed works better. Yeah? Teach small, frequent meals instead of large meals that stretch the stomach. Avoiding lying down after eating. Usually the teaching is to wait a few hours before bed. Avoid trigger foods if they worsen symptoms. Caffeine, chocolate, peppermint, fatty foods, spicy foods, right? Citrus, tomato, and alcohol. Oh my God, no alcohol. Stop smoking, all right? Because nicotine can relax the LES, right? And weight loss can help with abdominal pressure, is contributing to reflux, okay? So the framework point here is the nursing teaching and priority. If the question asks for initial teaching for uncomplicated GERD, lifestyle changes are usually the clean answer before jumping straight to the medication, okay? Think of it like GERD teaching is pressure control. Less pressure in the stomach, less acid, right? Pushed through the weak door. Copy? Okay. PPIs like omeprazole or pantoprazole, right? Reduce acid production at the proton pump. They are usually taken 30 to 60 minutes before the first meal, so the drug is available when acid pumps activate. Yeah? So they are strong, but they are not instant. It can take a few days to feel the full effect. H2 blockers like famotidine reduces acid by blocking histamine 2 receptors on the parietal cells, right? The parietal cells, right? They are often used for milder symptoms or nighttime symptoms, depending on the plan. Okay, so antacids like calcium carbonate or magnesium or aluminum products naturalize acid that is already present. They work fast, but they are short acting. The teaching trap is the antacids can interfere with absorption or timing of other medications. So they should be separated from other meds according to the course or the medication guidance. Yeah? So my simple medication map is PPI prevents strong acid production. H2 blocker reduces acid signaling. Antacids naturalize acid already there. Copy? So the issue is rebound acid hypersecretion. Okay, say it with me. Rebound acid hypersecretion. If the patient has been on PPI and suddenly stops, the stomach can temporarily produce more acid than before. That can make symptoms feel worse and make the patient think that the medication has failed, but you stopped it, right? So the teaching is to take it as prescribed. Don't stop suddenly without guidance, huh? Right? And follow the taper or the step down plan if the provider gives one. All right. I also want to know if the patient is using over the counter PPIs for longer than intended. So, because long term use can be associated with risks like low magnesium, B12 deficiency, bone concerns, kidney concerns, and C. diff risk. Yeah, right? The exact risk depends on the patient and the duration, but the nursing point is to monitor and avoid unnecessary long term use. Yeah, so what I teach is not PPIs are bad. The better teaching is use the medication correctly. Yeah, pair it with lifestyle changes. Report red flags and follow up if symptoms persist. Yeah? Okay. So, two major causes are H. pylori and NSAIDs. H. pylori is bacteria that can weaken the protective mucosal layer, right? And promote ulcer formation. It is commonly connected to the duodenal ulcers, right? The classic duodenal ulcer pattern is pain that improves with food and returns a few hours later when the stomach empties and acid continues irritating the area. NSAIDs like ibuprofen or naproxen reduce prostaglandins. Prostaglandins normally help protect the stomach lining by supporting mucus and bicarbonate. When that protection drops, acid can injure the lining more easily. NSAIDs-related ulcers are often gastric, and pain can worsen with food because the stomach is active and irritated, right? So I want the cause to tell the story. Bacteria breaks protection from one angle. NSAIDs remove protective prostaglandins from another. Either way, acids meet vulnerable tissue. Think of H. pylori is the introducer, right? NSAIDs remove the stomach's protective raincoat. In both cases, acid gets access to the tissue it should not burn. Yeah? Okay. Okay, so duodenal ulcer pain may improve with food and come back 2 to 3 hours later. Gastric ulcer pain may worsen with meals. That timing is not perfect in real life, but is a common clue. So I also assess for nausea, right? Bloating, early signs of bleeding, hematemesis, right? Means vomiting blood. Coffee ground emesis suggests older blood exposed to the stomach acid. And melena means black tarry stool from the digestive blood. These findings matter because ulcers can bleed. The complication chain is the point. Yeah, so ulcer deepens, blood vessels erode, bleeding occurs. If the ulcer perforates, continence can leak into the peritoneal cavity, right? So causing peritonitis and sepsis. So I'm watching for severe, sudden abdominal pain, rigid abdomen, fever, tachycardia, hypotension, and worsening conditions. Okay? Think of an ulcer as like a pothole in the lining. The deeper it gets, the closer it gets to blood vessels and the outside wall. So, for H. pylori treatment, the important teaching is completing the full regimen exactly as prescribed. Many course materials teach him like a 14-day regimen, and the exam trap is stopping early because symptoms improve. The common idea is acid suppression plus antibiotics. If the plan includes a PPI with antibiotics such as amoxicillin and the clarithromycin, the patient needs to finish the full course. If nitazole is the part of the regimen, the teaching is no alcohol during therapy and for the recommended period after the last dose because of the dyslipidurium, right? Like reaction risk. What I need to say clearly as a nurse, feeling better does not mean the bacteria is eradicated. If treatment is incomplete, therapy can fail and resistant risks can increase. So the patient should take the medications on schedule, report severe side effects, and complete following up testing if ordered. So, for an example, an exam angle is teaching and compliance. So the most correct answer is often the one that keeps patient on the full regimen and avoids alcohol when metronidazole is involved. Okay? So smoking can also increase acid-related problems and raise recurrence risk. So smoking cessation teaching is not a side note, it's part of the ulcer care, right? So if a question asks what to teach a patient with PUD who smokes, I should not only think about medications, I should think about healing conditions. Stop the irritant, protect the lining, improve blood flow, and reduce recurrence risks. Yeah? Don't you love my cute images? Look at that. Look how cute that is. Huh? Anyway, so the common sliding types can act like GERD, right? Because the stomach and the lower esophageal sphincter position changes, making reflux more likely. Nursing care often looks similar to GERD teaching: small meals, head of the bed elevation, avoiding late meals, and reducing reflux triggers. The paraesophageal type is less common but more dangerous because part of the stomach can become trapped. If the stomach twists or loses blood flow, strangulation can occur. That is when hiatal hernia stops being a routine reflux problem and becomes an emergency, right? So my framework separation is sliding equals reflux style management, right? So paraesophageal with strangulation signs equals emergency. Okay, so sliding hernia is the stomach peeking upstairs, right? That's your memory hook, yeah? And the paraesophageal danger is the stomach getting stuck upstairs with the blood supply threatened, okay? The emergency version of hiatal hernia is strangulation or volvulus type presentation, okay? So the concern is that the stomach can twist or become trapped, cutting off blood flow. The signs I want to remember are sudden severe chest or epigastric pain, difficulty swallowing, and retching or inability to vomit. Some materials also emphasize inability to pass an NG tube with gastrovolvus, right? The point is the same. This is not normal reflux anymore. So the nursing action is to recognize the emergency and escalate, right? Severe pain plus obstructive symptoms mean provider notification, right? Preparation for urgent evaluation and possible surgical management. I should not treat this like simple GERD teaching, yeah? Okay. Gastritis is inflammation of the stomach lining. It can be connected to NSAIDs, alcohol, infection, stress-related mucosal injury, or other irritants. Symptoms can include epigastric discomfort, nausea, vomiting, fullness, and sometimes bleeding. Dyspnea is more of a symptom label. Indigestion or upper abdominal discomfort, it does not automatically mean inflammation was seen. So I separate them this way. Gastritis is an inflamed lining. Dyspnea is the complaint of upper GI discomfort. Okay, so here's your memory hook. Gastritis is the stomach lining looking irritated. Dyspnea is the patient saying, my upper stomach feels off. Okay? All right. So the goal here is comparisons. IBS versus IBD. UC versus Crohn's, okay? Diverticulitis versus appendicitis, right? Small bowel obstruction versus large bowel obstruction. Right-sided colon cancer versus left-sided colon cancer, right? So lower GI questions often test whether I can identify the pattern and avoid treating one condition like another. So I'm going to slow down and make the differences clear, okay? Okay. Wow, I love what I did here. Don't you like these images? Come on, leave a like or a comment or something, all right? Let me know if you like the slides. Okay, so IBD means inflammatory bowel disease, right? This is a structural inflammation. So the bowel tissue is actually inflamed and damaged. IBD includes ulcerative colitis and Crohn's disease, right? So labs may show inflammation such as elevated CRP or ESR, and stool markers like calprotectin may be elevated, right? So endoscopy or biopsy can show damage. So for an example, the exam differences is simple but important. So IBS is symptoms without visible inflammatory damage. IBD is inflammation with projective evidence and complications. So if the question gives normal labs, normal colonoscopy, cramping relieved after bowel movement, and no bleeding, I think IBS. If it gives bloody diarrhea, weight loss, fever, elevated inflammatory markers, or ulcerations on the scope, I think IBD. Okay, so IBS is the bowel being irritated. IBD is the bowel being inflamed and damaged. Okay? Okay. So, both can have flares and remissions, but both can cause abdominal pain, diarrhea, weight loss, fatigue, and inflammatory lab findings. Both can require medications that reduce inflammation or suppress the immune responses. Both can have serious complications, but I cannot leave them under the umbrella in my head. I need to split them, right? Because UC is colon and rectum, continuous and mucosal and potentially curable with a colectomy, right? Crohn's can happen anywhere from the mouth to the anus, has skipped lesions, is transmural, and is not cured by surgery. That split is the whole exam trap, right? That's the game, okay? You got to differentiate, okay? So another one, another memory hook. IBD is the family name, right? So UC and Crohn's are siblings, but they do not live in the same room and they do not damage the bowel the same way, okay? So the inflammation is usually limited to the mucosa and the submucosa because the colon lining is inflamed. And ulcerative, the classic symptom is bloody diarrhea. Patients may also have urgency, cramping, weight loss, fatigue, and tenuous, right? Which is the feeling of needing to keep passing stool even when the bowel is empty. So the key memory point is that UC is colon only because the disease is limited to the colon and rectum. Removing the colon can remove the disease source. That is why colectomy, right, can be curative for UC. What can go wrong? Severe bleeding, dehydration, anemia, toxic megacolon, right? Perforation, and increase colorectal cancer risk over time. Hmm? Crohn's is transmural, meaning it can affect the full thickness of the bowel wall. That is why Crohn's is associated with strictures, fistulas, abscesses, and obstruction. If inflammation goes through the whole wall, abnormal tunnels and narrowing can form. So symptoms can include abdominal pain, often in the right lower quadrant when the terminal ileum is involved, diarrhea, weight loss, malabsorption, right? Fatigue, and sometimes oral ulcers. Surgery can remove damaged sections, but it does not cure Crohn's because the disease can recur somewhere else in the GI tract. So the key contrast is UC can be surgically curable, Crohn's is managed, not cured by resection. Okay? So UC, colon and rectum only, right? Continuous inflammation, mucosal and submucosal, bloody diarrhea is common. Colectomy can be curative. Crohn's, anywhere from the mouth to the anus, skip lesions, transmural inflammation, right? Fistulas, strictures, abscesses, malabsorption, obstruction are more Crohn's style complications. Surgery is what? Not curative. So if the question says continuous rectal involvement, bloody diarrhea, and colectomy, I think UC. If it says skip lesions and terminal ileum, fistulas, strictures, or mouth ulcers, I think Crohn's. Yeah, nice. This is the differential point of the framework, right? What confirms it and what rules it out. All right? So, toxic megacolon is the emergency version I need to connect to IBD, especially severe colitis. The colon becomes massively dilated, right? Inflamed and at risk for perforation. The patient may have abdominal distension, severe pain, fever, tachycardia, dehydration, tenderness, and signs of systemic toxicity. All right, this is not routine diarrhea. This is unstable colon that can rupture. The medication trap is antidiarrheals, such as loperamide, right? During an active severe IBD flare, slowing the bowel can worsen dilation and increase risk, right? Opioids can also slow motility and complicate the picture. The nursing response is to recognize the emergency, keep the patient NPO as ordered, monitor vitals, abdominal assessment, labs, and prepare for urgent treatment. The key exam phrase is do not give antidiarrheals, all right, in active severe IBD when toxic megacolon is a concern, right? So think of toxic megacolon as a swollen, angry colon. Do not put a cork in the angry colon, all right? That's your memory hook. Amino salicylates, okay, such as mescaline, reduce inflammation in the bowel lining and are commonly used in ulcerative colitis, especially mild to moderate disease depending on the plan. Corticosteroids such as prednisone are used for flares because they calm inflammation quickly. The teaching point is that steroids are not ideal long term. Maintenance because of the side effects like infection risk, hyperglycemia, bone loss, mood changes, and adrenal suppression. Use for the flare, then taper as prescribed. Immunodilators and biologics such as anti-TNF medications like Inflamix or infliximab or adulimab are used for more moderate to severe disease or refractory disease, right? The safety point is infection screening, including TB screening before biologic therapy. So the nurse should also teach infection precautions and when to report fever or signs of infection. The exam is usually asking, what is the purpose? What do I monitor? And what teaching keeps the patient safe? Right? So IBD meds are a fire control ladder, right? Local anti-inflammatory flare and steroid, then bigger immune targeting tools when the fire keeps spreading. Diverticulitis means one or more pouches become inflamed or infected. Now, the patient can have left lower quadrant pain, fever, elevated WBCs, nausea, constipation or diarrhea, and localized tenderness. The exam comparison is appendicitis. Diverticulitis is classically left lower quadrant. Appendicitis is classically right lower quadrant. Both can have fever and leukocytosis. So the location helps me sort the question. So complications of diverticulitis include abscess, perforation, peritonitis, fistula, obstruction, and sepsis. So I do not treat it as simple belly pain if the patient has fever, worsening pain, guarding, or signs of perforation, right? So think of diverticulitis usually lives on the left. Appendicitis usually screams on the right, all right? So during an acute flare, the bowel is inflamed, and the goal is the bowel rest and infection management. The patient may be NPO or clear liquids, depending on severity, receive IV fluids, antibiotics if ordered, pain control, and monitoring for perforation or abscess. After the flare resolves, teaching shifts, right? Fiber may be increased gradually to prevent constipation and reduce pressure in the colon. Hydration matters, right? So regular bowel habits matter. The timing is the exam trap, right? So the low residue or bowel rest during acute inflammation, higher fiber for long-term prevention after recovery. I also want to avoid outdated seed and nut fear unless the current course specifically is tested, right? So the more current teaching usually does not require universal avoidance of seeds, nuts, or popcorn, right? But think of it like this. During the flare, let the bowel rest. After the flare, feed the prevention plan, okay? So, small bowel obstruction is often related to adhesions from prior surgery, hernias, or inflammatory narrowing. Think of adhesions as it sounds, right? So, adhesiveness, yeah? Uh, think of literal like organs kind of stuck together, right? And obviously, because I work in surgery, I see this from time to time where you kind of have to like cut it out and make sure the bleeding doesn't, thing. Anyway, not to go too much deep into that, but it is a problem, right? So, because the blockage, right, is closer to the stomach, vomiting tends to happen earlier and can be more prominent, right? So, pain is often crampy and intermediate. So, distension can occur, but may be less dramatic than large bowel obstruction, depending on the location. Large bowel obstruction is often related to colorectal cancer, right? Valvulus or strictures, because the blockage is further down. Constipation and inability to pass stool or flatulence are early clues. Vomiting is later, and abdominal distension can be more pronounced. The logic is the location. If the backup is high, it reaches the stomach faster. If the backup is low, the colon swells and stool and flatulence stop. Right? So think of small bowel is closer to the mouth. So vomiting shows up earlier. Large bowel is closer to the exit. So constipation and distension take over. Okay? Early obstruction can have high pitched tinkling bowel sounds because the bowel is trying to push the contents past the blockage. Yeah? So late obstruction or paralytic ileus can become hypoactive or absent. Vomiting causes fluid and electrolyte loss. Yeah? Especially potassium loss. Ding, ding, ding. Low potassium can worsen bowel motility. So electrolytes matter. Okay, imaging may show air fluid levels, yeah? Dilation or the obstruction pattern. Labs may show dehydration, electrolyte imbalance, leukocytosis, or signs of worsening perfusion depending on the severity. The red flags are continuous severe pain, fever, tachycardia, gardening, rigid abdomen, rebound tenderness, right? Hypotension, metabolic acidosis, rising lactate, or sudden change in condition. So those suggestions, ischemia, perforation, peritonitis, or sepsis. Okay, here's your memory help. An obstruction starts as a traffic jam. The danger is when the pressure cuts off blood flow and the road wall breaks. Yeah? All right. So, NPO means nothing by mouth, okay? So, more continents are not added above the blockage. NG tube, decompression removes gastric contents, all right, and air. So, decreasing vomiting and reduces pressure. IV fluids treat dehydration, and third spacing, strict intake and output helps monitor perfusion, especially kidney perfusion, right? Electrolyte replacement, especially potassium, may be needed. Pain control and antiemetics may be ordered, but I want to be careful to keep reassessing. If the changes from intermediate cramping to constant severe pain, or if the abdomen becomes rigid, right, that is not routine obstruction anymore. So if if conservative management fails or there are signs of strangulation, ischemia, perforation, or complete obstruction, surgery may be needed. Okay? Risk factors include age, family history, inflammatory bowel disease, certain genetic syndromes, smoking, obesity, alcohol use, and diet patterns. But for the test questions, the presentation often depends on the tumor location. So, right sided colon cancer may bleed slowly because the right colon is wider and stool is more liquid. The patient may present with fatigue and iron deficiency, anemia before obvious obstruction. Left sided colon cancer is a narrower area where stool is more formed. It is more likely to cause change in bowel habits, constipation, narrowing, or pencil thin stools, and obstructive symptoms. So the memory split is right sided bleeds quietly and causes anemia. Left sided blocks sooner and changes stool patterns. Okay, so here's your hook. Right sided hides and bleeds, left sided narrows and blocks. All right. So teach clear liquid instructions and medication instructions according to the provider plan, right? Especially anticoagulants, diabetes medications, and other meds that may need adjustment. So after a colonoscopy, right, mild cramping, bloating, and small amounts of bleeding can occur, especially if there is a biopsy or a polyp removal was done. But heavy bleeding, fever, and severe abdominal pain, rigid abdomen, dizziness, or signs of perforation need prompt reporting. CEA, right, carcinoembryonic antigen, is not a screening test by itself. It is often tended after colorectal cancer treatments to monitor for recurrence or response. So think of your colonoscopy prep is cleaning the windshield. If the windshield is dirty, the provider cannot see the road. All right. So this is the chain. An obstruction blocks movement, right? Continence and gas buildup behind the blockage. Pressure increases inside the bowel. A pressure rises. Blood flow to the bowel wall can decrease. Poor blood flow causes ischemia. Ischemic tissues can die. Oh, this is making sense, right? So dead or weakened bowel wall can perforate. Whoa. Once bowel contents enter the peritoneal cavity, the patients can develop peritonitis and then what? Sepsis. Yeah, that is why I do not only memorize bowel obstruction equals NG2. I need to understand what the NG2 is trying to prevent, right? So, worsening pressure, vomiting, aspiration risk, fluid loss, and progression towards ischemia and perforation. The clinical warning signs are rigid, board like abdomen rebound tenderness, right? Fever, tachycardia, worsening pain, hypotension, altered mental status, and signs of sepsis. When those appear, this is no longer just a waiting game, it becomes urgent escalation. Okay, so think of it like this. Blockage builds pressure, pressure kills blood flow, low blood flow kills tissue, dead tissue breaks. Break means bacteria, where bacteria should not be. Okay? So, PPIs reduce acid production and are usually taken before the first meal, right? H2 blockers reduce acid signaling and may help with nighttime symptoms. Antacids naturalize acid already present and should be spaced from other medications when required because they can't interfere with absorption. For PUD related to H. pylori, the patient must complete the full regimen. If metronidazole is included, teach no alcohol during therapy and for the recommended time after the final dose. For IBD, mesmelamine is an anti-inflammatory option, especially in UC, right? Steroids are for flares, not casual long-term maintenance, okay? So biologics require infection screening and patient teaching about infection risk. So for active severe IBD flare, do not casually give antidiarrheals when toxic megacolon is a concern. The medication that seems helpful can become dangerous if it slows and it's inflamed colon. Okay? Think of like GI meds are not random. Acid meds protect tissues, right? H. pylori meds eradicate bacteria. IBD meds calm immune inflammation. Antidiarrheals can be dangerous when the colon is inflamed and dilating, all right? So use it as a follow along tool. Watch the section, pause, look at the map, then answer the questions. This is how I want the video and the packet to work together, right? The video gives the explanation, my notes give the visual structure and the practice, okay? And subscribe if you want the next GI video. Liver and pancreas is next, and that one is all about cirrhosis and hepatitis, pancreatitis, gallbladder, and the emergency change that come with them, all right? So for every condition, define it, picture it, name it, and what can go wrong, right? This is all my techniques and chains, all right? So that's how I am studying this. This is how I'm teaching myself. And if it helps you too, I am genuinely glad. Pull up my notes and run the practice questions and come back to the video if something starts slipping before the exam or if anything. But the one thing I want to tell you is that you got this, right? I got this. We got this. All right. Tiago out.